So without further ado, I'd like to introduce our two presenters. First up, we have Dr. Maeve MacMurdo. Dr. MacMurdo is a specialist in occupational and environmental lung disease and the director of the Cleveland Clinic's Occupational Lung Disease Center. Her research focuses on understanding how exposures in the environment and on the job impact the risk of developing sarcoidosis and other interstitial lung diseases. And then our next presenter will be Dr. Logan Harper. Dr. Harper is a clinical associate with Cleveland Clinic's Sarcoidosis and Interstitial Lung Disease Program. Dr. Harper completed his undergraduate work at Penn State before receiving his medical degree from Thomas Jefferson University in Philadelphia. He completed his training in internal medicine, pulmonary and critical care medicine at Cleveland Clinic and was appointed to Cleveland Clinic in 2020. Dr. Harper's clinical focus is seeing sarcoidosis patients and working collaboratively with our team to provide holistic care. He is also a part of our community lung clinic here at Cleveland Clinic and focuses his research on improving care for disadvantaged sarcoidosis patients. And in his spare time, he enjoys spending time with his wife, daughter, enjoying hiking, cooking, and exploring local Cleveland restaurants. So I will kick that over to you, Dr. MacMurdo.
Dr. Harper, that was a much more thorough bio than my bio. I'm already impressed. I'm going to go ahead and share my screen. Bear with me because WebEx is WebEx. All right, are you seeing a PowerPoint slide?
Yes, we are.
Excellent. So I'll go ahead and get started. So as Rhonda mentioned, I'm one of the specialists in occupational environmental lung disease here at the Cleveland Clinic. And really what that means is I spend a lot of my time thinking about how people's work, how their environment can either make their sarcoid worse or can kind of impact how we control their sarcoid. And so today I'm going to kind of give an overview about what we know and really what we don't know about how the environment and how where you work can impact your sarcoidosis. I'm going to try and hit three main points. One, how where you live might impact your risk of sarcoid. Two, how work and work-related exposures can impact sarcoid. And then finish up by talking about how the environment might impact how your sarcoid actually controls and whether you're at risk of your sarcoid flaring. So fairly ambitious. Again, I'm going to try and stay on time and try and leave some room for questions at the end. I want to start by kind of giving some framework and some caveats, which is that really understanding how sarcoid and the environment play together is really, really complicated. And it's complicated for a couple of different reasons. One, sarcoid is probably a lot more common than we think. And the reality is a lot of people who have sarcoid don't get diagnosed until the disease is pretty severe or pretty advanced, because sarcoid can be hard to diagnose and hard to recognize, especially because sarcoid doesn't always read the rule book. Many of you know that you can have isolated cardiac sarcoid, sarcoid which is just in the heart, sarcoid which is just in the brain, sarcoid which presents in a way that doesn't fit that typical textbook version of sarcoid. And because of that, when we're thinking about how we study the environment in sarcoid, there's a risk of bias in that the people who get diagnosed with sarcoid are probably only a subset, a kind of chunk of the overall population of people who actually have sarcoid in the United States. The other challenge is when we think about environmental exposures and kind of where they are in the United States. We know that people who live in neighborhoods who already face challenges accessing healthcare, who face challenges getting time off work, who face challenges in other exposures, also probably live in neighborhoods where there's an increased risk of exposure to things which may increase your risk of sarcoidosis. And so the people who may be most likely to have sarcoid are also the ones who may face the most challenges to getting diagnosed. And so this becomes really important to understand when we look at the data we have, because there are a lot of challenges with trying to study and trying to answer this question. The other major challenge is that exposures don't occur in isolation. When we think about one person and kind of what they face throughout the day, it's things like smoking, it's things like diet, it's things like the pets in your house, it's things like exercise. Those are things you can control to some extent. They're not all the way, but there are also things you can't control, like the air pollution you experience, like the traffic you drive into work, like the kind of job you do and the kind of exposures you have on the job, or the kind of conditions inside your home, whether you have a damp, moldy home, whether you have a clean, dry home. And all of those things don't just work one by one, but they're all working in combination, which again means that sometimes it's challenging to tease out because you think about exposures, often they come together. You aren't just experiencing one exposure, you're experiencing multiple things again happening all at once. So really, when we think about sarcoid in the environment, what we think is that it's probably a combination of exposure, your genes and your genetic risk factors, which then merge together and in combination create that risk of developing sarcoidosis. So it's complicated. But what do we actually know? Probably the strongest data we have so far comes from the series that we call case control and cohort studies. So for those of you who might not be kind of aware of what I'm talking about here, a case control study is basically a type of research study. We take people who have a disease like sarcoid and then match them to controls, people who do not have sarcoid, who are the same age, same gender, often same race. We then go and ask everybody kind of what you were exposed to and what you weren't exposed to. And we can then look at whether exposure differs between people who have the disease, so who have sarcoid, and people who don't have sarcoid. Now, case control studies aren't perfect. As you can imagine, sometimes if you're not sick, you may not spend much time thinking about what you were exposed to. And recruiting controls who are healthy can be challenging. But this is probably the best way we have of really looking at environmental exposures. And the biggest case control study looking at this risk in sarcoidosis is something called the ACCESS study. This involved 736 patients across the United States living with sarcoidosis. And really what they did was ask these patients a really extensive list of their occupational, so their work-related, and their environmental exposures. There were some challenges here. Because they asked so many different questions, it was actually really hard to tease out what was most important. But what they did find that there were a couple of exposures that probably were significant. Exposure to industrial insecticides, so pesticides, agricultural exposures, working and living in a rural area, and then working or living in an environment that was musty or moldy, were all shown in this study to have be associated with an increased risk of developing sarcoidosis. So it was more common in the cases than it was in the controls. But this study had some limitations. It wasn't the kind of slam dunk study we'd hoped for. I think still though it's really important because it gives us some kind of flags and things to go after. A lot of the time people ask about mold and mildew in the home and kind of what that means for them. And we know as pulmonologists that mold in the home can make it harder to control asthma and can increase the risk of some kinds of autoimmune lung disease, something called hypersensitivity pneumonitis or HP. There have been several studies, including the ACCESS study, that have linked exposure to indoor and outdoor mold to an increased risk of sarcoidosis. And probably what's most important is that in one study, what we found was that people who had sarcoid, when we checked the levels of mold in their home, we found that the higher the concentration of mold in the home, the more likely you were to have sarcoid that was difficult to control, or recurrent sarcoid that didn't just come on and then go away. This is helpful, but it also raises a lot of questions we can't answer yet. We don't know which mold causes problems because there are multiple mold species and probably only some of them actually are harmful. Some of them may be actually helpful. We don't know how much mold is too much mold. Is seeing mold in the bathroom a risk factor, or does it really have to be like a fully moldy basement and really extensive mold involvement? And then we also don't know when. Does it matter if you're exposed to mold growing up? Or is it really only important if you're exposed to mold around the time you develop sarcoidosis? Again, there are a lot of questions we need to answer in this space, and so it's challenging to really give a clear slam dunk. But what we can say is that probably mold and sarcoid are linked in some way. And if you do have mold in your home and you have sarcoid, we want to see that remediated and kind of fixed if we can. But again, to get back to my earlier point, mold exposure doesn't occur in isolation. And so it may be that the mold is actually a surrogate, so a sort of flag for another exposure that we're not capturing, which goes along with mold in the home. So that's mold. How about, oh my God, animation, agricultural exposures and farming exposures? So there's been concern for a long time that people who live in rural areas and who live in the country may have an increased risk of sarcoidosis. And this hasn't just been in America. There's been a number of studies in Denmark and Sweden that show that people who live in rural areas may have more sarcoid than those who live in cities. And again, we take this data with a bit of a grain of salt because it may be people who live in cities have a hard time getting diagnosed with sarcoid. We don't know. But when we look at what could be a risk factor and kind of what could trigger an increased risk of sarcoid in these rural areas, there are a couple of things we worry about. We worry about things like animal proteins, so hog proteins, poultry proteins, because we know that those proteins can trigger, again, poor asthma control and can also trigger that autoimmune lung disease, HP, that I talked about earlier. We worry about moldy hay, and again, mold and hay. We talked about mold and sarcoid. Mold and hay can also trigger that autoimmune lung disease known as HP. We worry about pesticides, which are increasingly being linked to a number of health complications, particularly things like asthma and poor airway control. And then we think about things like wood-fired smoke and wood burning, because as I'm going to talk about later, there's actually increasing data linking air pollution to poor sarcoid control. And some people wonder whether air pollution, particularly that really, really high level air pollution that comes from wood burning stove in the home, could be a trigger. But again, a lot of unknowns here. We have some signs and clues, but not a slam dunk answer. I'm just going to say again and again, unfortunately. There's been a lot of interest in whether sarcoid could be linked to an occupational exposure. And unfortunately, like the environmental data, this really isn't as clear cut as we'd like it to be. This table here shows all the jobs that have been studied and have been linked and tested and queried about whether they could be related to sarcoid. And what we see is really a couple of things. One, we see that, again, agricultural exposures to animal proteins probably seem to increase the risk of sarcoid. We see an increased risk in things like automotive work and transportation, and we'll talk more about why that is pretty shortly. And then some things that we wouldn't expect, like teaching, like education, like childcare. And no one quite knows why that is. There's some theory that maybe there's kind of chronic low-grade exposure to viruses to people because kids get sick and kids get you sick might kind of prime the immune system, but that's really, again, a big unknown. But there are some exposures that we know can cause sarcoid, and I want to talk about them here. I think it's, again, important to recognize. So a lot of what I do today is day-to-day is caring for patients with beryllium disease. So beryllium's a metal which is widely utilized in things like aerospace, nuclear weapons development, but also in some strange places. It's found in sandblasting materials, it's found in dental alloys, and we know that people who cut or machine beryllium, who inhale beryllium dust, can develop basically what we call an allergy to beryllium. We call it beryllium sensitization. And of those, some will go on to develop something that looks a whole lot like sarcoid with granulomas, but this history of being exposed to beryllium. Now, this is actually a separate disease called chronic beryllium disease, but in many ways it looks exactly like sarcoidosis. And without the occupational history, it's very challenging to tease out. But unlike sarcoid, we can actually screen for the sensitization to beryllium for a blood test and say you've been exposed, you've got the sensitization, and kind of make the diagnosis that way. Now, people often ask when they hear about dental alloys and whether they've got beryllium in their dental alloys and then whether that's a risk. And the answer is no. The risk comes from cutting and grinding beryllium. If you have beryllium in your dental implants, you're okay. The person who placed them, though, so the person who made the implants, might be at risk. The reason I bring up beryllium and the reason I think it's important to highlight is because we don't always know when people are exposed. So a recent study looked at a series of cases of, or a case of sarcoidosis in Germany. This is a patient who worked in a building lot which was right next to a cement plant. And every day the dust from the cement plant would blow into the factory yard where he worked. He developed what people thought was sarcoid, and they were very concerned that he had sarcoid. But he went to his doctors and said, hey, the cement dust is constant, and I'm kind of worried this could be linked. And so they actually went ahead and screened him for beryllium sensitization and found that he was beryllium sensitized. They went ahead and screened his co-workers and actually found that several of them had beryllium sensitization as well. When they looked at the actual dust, what they found was that the dust in the building yard, the dust coming from the concrete, contained a really high level of beryllium, and that was basically triggering this allergy, the sensitization in all these workers. So this is not a common exposure, but the reason I talk about this is that, again, if we don't ask about what jobs people do, if we don't think about occupation, we can sometimes label people with sarcoidosis and not actually capture the real disease, which is important when you're thinking about how we screen people as co-workers and how we think about long-term risk. Beryllium is not the only metal. Again, magnetite, aluminum, I'm going to say it properly in like an American, titanium, zirconium, nanoparticles have all been linked to this granulomatous-like disease that can look like sarcoid. But the most important metal, and the one that I spend a lot of time thinking about, is something called silica. So silica dust, or respiral-crystalline silica, is everywhere. We see it in mining and the rock people cut to get to coal mines. We see it when we cut marble or cut engineered stone to make kitchen countertops. We see it in foundry sand in the steel mills, and we see it now in fracking with, again, fracking sand. There's increasing data that silica exposure may increase the risk of developing sarcoidosis. And we know that silica exposure can trigger an autoimmune response and increase the risk of other autoimmune disease, so it makes sense. A Swedish study found that people who've been diagnosed with sarcoid in Sweden were more likely to have worked with silica prior to their diagnosis. And we see in coal miners who get diagnosed with, again, black lung or coal carcinosis, that several of these patients, particularly those who work in mines where the rock contains a large amount of silica, actually have signs of sarcoidosis as well. And so silica and sarcoid may go together, and silica may, in fact probably does, increase the risk of developing sarcoidosis. We also know that disasters, so acute events, can lead to clusters of sarcoidosis. And probably the best example of this comes from the World Trade Center. So all of you probably remember 9/11. And what we saw after 9/11 was that as those buildings came down, the first responders, those on the ground, were exposed to a highly irritating mixture of asbestos, of silica, of particulate matter, and then of other building materials, all in really, really high concentrations. What we see now is that those firefighters, those first responders who are on the ground, particularly in an initial couple of days, have a significantly increased risk of sarcoidosis. And similarly, people who are in that immediate community, people who lived in that area who are exposed to the dust cloud, also have a higher rate of sarcoid. Now, we don't know what in that cloud was the trigger. We probably never will. The reality was that it's very hard to tease out one thing. But what we do see is that people who had this World Trade Center sarcoid seem to have more heart involvement, more joint involvement, and seem to have more severe pulmonary disease. And we look at who's at the most risk. Those who are working right in the debris pile, those who are the most exposed to the initial dust cloud, have the highest risk of developing severe sarcoid. We are concerned, we've worried for a long time, that may not just be things like this, that firefighters may have a higher risk of sarcoid overall. That data is a little bit harder to tease out, but there is some studies that suggest that may be the case. But what we really do see is that, again, post-disasters like this, because of that heavy dust load, because of that acute exposure, there's an increased risk of long-term disease. And we wouldn't have found it unless we looked for it. I bring that up because what we are seeing now is among deployers, people who have served in the US military, an increased risk of sarcoidosis. Now, this isn't actually new. We first saw this way back in the 60s and 70s in people who worked on naval ships, and we didn't know why that was. But interestingly, despite not knowing why it was, as ships got cleaner, that trend went away, and the rates of sarcoid in the Navy really became normal for the population. But what we're seeing is that post 9/11, a lot of people have come back from serving in places like Iraq and Afghanistan and have developed sarcoidosis. And again, we don't know exactly what the exposure is that triggered it, but there are multiple potential things like burn pits, like diesel exhaust, like sandstorms, which contain silica, the munitions and artillery fire. The reason that I think it's important to highlight this is that actually now, with the PACT Act, sarcoidosis is recognized as presumptive, meaning that if you served in that area, in the Army, Navy, or Air Force, and you develop sarcoidosis after your service, you are eligible for coverage through the VA. I want to take a second to plug this here and just highlight that the PACT Act extended coverage for a number of other things, not just sarcoidosis. And so if you or someone you know served in the US military during the post 9/11 era and have things like asthma, like ILD, or like sarcoid, you may be eligible for coverage, but there is a timeline to file. And so it's really important that you talk to your VA rep or talk to your pulmonologist about this and kind of see whether you're eligible. Because again, the more people who flag they have sarcoid to the VA, the more we can follow this, the more we can study this, the more we can actually understand what that link really is. So we talked about work-related exposures, but the reality is that most people do not work in jobs where they're exposed to beryllium or exposed to silica. I want to finish up by just briefly talking about an exposure which is relevant to everybody, which is the air we breathe and air pollution. So air pollution is bad for you. There's really no question about it. It causes health impacts really starting from before you're born, going through to things like an increased risk of heart disease, of diabetes, of stroke, of dementia, of lung disease, and of wrinkles, most importantly. And so air pollution really is a whole body exposure. When we think about what air pollution is, it's really not just one thing. It's things like particulate matter, PM2.5, like ozone, like nitrogen dioxide, like volatile organic compounds like formaldehyde, all of which can harm the lung and harm the body in different ways. And it comes from a number of different sources. Sarcoid and air pollution is still not that well understood, but a lot of what I'm doing and a lot of the work I'm doing is really focused on trying to understand this better. Right now, what we know is pretty limited, but I want to highlight this because, again, it's an exposure which impacts all of us. Really, what we know is that people, when we look at population studies, when the rates of nitrogen dioxide of fine particulate matter, PM2.5, start to climb, we see an increased rate in the flares of acute sarcoidosis. Similarly, when you look at people in America, people who have severe fibrotic sarcoidosis, so bad sarcoid of the lung, when they experience higher concentrations of particulate matter, PM2.5, they had worsening quality of life and they had a significant increase in cough and wheezing and shortness of breath, which makes sense. Again, it's something you're inhaling which is going to irritate the lung. But given the air pollution impacts all of us and the air pollution is to some extent preventable, I really think that air pollution and understanding how air pollution impacts sarcoid is one of the most important things that we can do as researchers moving forward. So, in summary, sarcoid in the environment is really complicated, but environmental exposures likely do play a role both in the risk of sarcoid and in how we think about sarcoid control and how stable your sarcoid is. We know certain jobs can increase the risk of sarcoidosis, but there's still more work needed here too because work is changing and exposure is always changing. Again, I'm biased, but I think understanding how air pollution impacts sarcoid is really important because it impacts all of us, and you can't stop breathing. And then finally, in terms of actually improving research and moving the field forward, the most important thing is really increasing awareness of sarcoidosis. Because the more people who get diagnosed, the more people who get treatment early, the more we can both improve quality of life, help prevent severe sarcoid, and actually understand what is causing and what's triggering a sarcoid. All right. With that, I'll finish. I think we're taking questions at the end. Is that right, Rhonda?
Yes, that is correct. Thank you so much for that wonderful presentation, Dr. MacMurdo. You answered a lot of the questions that we had already
Oh,
sent
good.
in, so thank you for that.
No, thank you for having me. I will stop sharing, but
And then, Dr. Harper, are you able to share your screen?
Yes, I'm getting everything all set up.
And while Dr. Harper's getting set up, don't forget, folks, you can go ahead and send your questions in the chat. And then again, at the end, I will read those off to our panelists. So go ahead and send those now while they're fresh in your mind, okay? Thank you.
Okay, is everyone able to see my screen and hear me?
Yes.
Okay, good. Hello everyone. As Rhonda said in that really nice introduction, I am Logan Harper. I'm one of the sarcoidosis doctors here at the Sarcoidosis Clinic. And today, what I'm going to focus on is how do we monitor sarcoidosis in all of the different organs to determine if we need to treat. This is really important because sarcoidosis is different from other diseases where if you have them, we just know that we have to treat it. In sarcoidosis, we see a lot of patients who the disease will go away over time and either never need treatment or no longer need treatment. We can see here that the chances of that are different for different people. We see in general more aggressive sarcoidosis in Black patients, and we see more aggressive sarcoidosis outside of the lungs. So I want to talk briefly about which organs can be involved and how we monitor them. Since sarcoidosis is a disease of the immune system, it really can impact any organ in the body. This chart here gives a general idea of what percentage of people have different organs involved. As you can see, the lungs are the most commonly involved, so that's where I'm going to start. When we think of sarcoidosis in the lungs, the most common way of categorizing it is by using the scatting stages. While they're called stages, I think of them more as types, because in general, patients don't go from stage 1 to stage 2 to stage 3. In general, people stay in one of these stages. As you can see, stage 1 right here, where you just have enlargement of the lymph nodes here in the middle of the chest, is the most common in 60% of patients, and goes away on its own most of the time, and frequently doesn't need to be treated. As you move through the stages, you see more scarring in the lung, and it becomes more rare for it to resolve on its own. Luckily, you also see that these higher stages are also less common. So once we see someone has sarcoidosis in the lungs, what we want to do is watch their lung function so we know if it's going away on its own. I'm sure many of you here have done breathing tests over the years. And I wanted to talk quickly about why we do them. The actual process of a breathing test is pretty simple. The idea is when you blow out through the tube, you fill up a chamber of air, which in the old days would move a piston through water, and now is just read by a computer, and it tells us all the different volumes in the lungs. Really, our main goal with the breathing tests is identifying, is your lung function normal, and as we check your lung function over time, is it staying stable? And what we'll do is use this data along with our imaging test to determine, is there progression of sarcoidosis in the lung, and do we need to treat? With the lung, we see two different types of problems on the breathing tests. The one type of problem we can see is something called restrictive lung disease, which you see over here. When someone has restrictive lung disease, there has been scarring of the lung, and it makes it so their lung volume's less, and that can cause shortness of breath and low oxygen. The other type of lung disease we can see with sarcoidosis is called obstructive lung disease. And that is a lung disease where patients have damage to the airways in the lung, which can cause mucus, and it can make breathing out very challenging, and that can also cause shortness of breath. By doing these tests, we can know what to follow and be able to treat to help improve patients' lung function. So, having talked about the lungs, I'm going to move on to the skin, which is one of the second most commonly affected organs. So, the skin's actually really easy to monitor the progress of, and we do this really primarily through the physical exam. Sarcoidosis of the skin can have many different findings. Sometimes it's very mild, just nodules under the skin that don't cause any symptoms, and other times patients very can have can have very aggressive rashes on their face, which is generally when we worry about it most. I have pictures over here of some other sarcoidosis skin involvement types. So here, we sometimes see sarcoid popping up where people have have had have had tattoos. Again, showing that maybe exposures are driving sarcoidosis in some patients. And then other patients can have these flatter rashes anywhere on their body. In general, when patients here have sarcoidosis of the skin, we have a pretty low threshold to send patients over to our dermatology colleagues first to confirm that it is sarcoidosis and not something else, and then to decide, is this a mild rash that we can treat with creams, or is this something that is more serious and we need to think about using more systemic drugs? The eyes are another organ that we're always particularly looking out for in sarcoidosis. In the eyes, sarcoidosis can cause a very wide range of symptoms. So it's something I always ask patients about at every visit. How's your vision doing? Are you having changes in vision? Are you having any pain or red eye or itchy eye? We generally, the main thing we are worried about in sarcoidosis is something called uveitis. The uvea is this anterior portion of the eye right here, involving all of these different structures. And in anterior uveitis, what we see is inflammation in the eye. And this is something where, working with our ophthalmology colleagues, we'll be pretty aggressive about treating this with either topical eye drops, sometimes steroid injections into the eye, and often systemic immunosuppression with pills or steroids. We also sometimes see sarcoidosis involvement of the glands around the eye where tears come from. This can cause swelling of the glands, as you see here in this picture, and it can also cause dry eye. Because of all these symptoms, we often have our patients with sarcoidosis see an eye doctor if they're having any issues, because our best way of monitoring eye symptoms in sarcoidosis is a really thorough eye exam. When they're doing an eye exam, the ophthalmologist has a lot of different tools at their disposal to figure out what's going on. The first thing they can do is something called a slit lamp exam. To do this, they put a special eye drop in your eye that'll make inflammatory cells fluorescent and easier to see. In this example up here, we have a close-up picture of a patient's pupil, and all of these little white dots in there are inflammatory cells. And this would be what we would see if someone had anterior uveitis. When someone's having anterior uveitis, we work really closely with our ophthalmology team to figure out how frequently do we need the eye eye exams, and to make sure that once we get patients on treatment, we're able to make the inflammation go away. Another thing that we can see in sarcoidosis is inflammation of the retina in the back of the eye. So this is a picture of a patient who has inflammation in the back of the eye. All of these little white spots are areas of damage following these blood vessels in the back of the eye. And this is again something where we would want to work with the eye doctor to figure out when we put the patient on treatment, were we able to control the inflammation and prevent these areas of damage from getting bigger and hopefully make them go away. Another component where patients with sarcoidosis need eye exams is if they're taking the medicine Plaquenil, also called hydroxychloroquine. This is a drug that can cause damage to the retina. This is a picture here of a patient who has pretty advanced toxicity from Plaquenil. So this is probably someone who wasn't being seen regularly by an ophthalmologist on Plaquenil and developed this damage. The recommendations currently are for anyone on Plaquenil to have a good eye exam one time a year, and that may become more frequent if the ophthalmologist sees something that they feel puts the patient at higher risk. So next I'm going to talk about the liver. So the liver is an example of one of the areas where we really run into that question I talked about in sarcoidosis of, do we have to treat what's going on? As that picture showed, liver involvement in sarcoidosis is actually pretty common. And if you go and look for it, it's not uncommon for a patient to have nodules in the liver. So this picture here is an MRI of a patient's abdomen. They're laying on their back. This is their spine right here, the top of their stomachs up here, and we're looking at their liver here and their spleen here. Often when the liver's involved, the spleen will be involved too. We're not sure why that is. And what we typically see are nodules. Even if a patient has nodules in the liver, most patients don't actually need to be treated. Talking to our colleagues over in the GI department, they very rarely see a patient who actually has end-stage liver disease from sarcoidosis. So typically what we do in the setting of a patient having nodules in the liver is we check blood tests. The nice thing about the liver is it is very active in cleaning the blood and creating some of the clotting factors and proteins in our blood. So on routine blood tests, we're able to see that the liver is still able to make all of those proteins and those clotting factors and isn't having any damage that is actually impacting its ability to function. We also look at other liver tests called liver function tests, which are measurements of injury from the liver. These tests are often mildly elevated when someone has liver injury from sarcoidosis, but if they're not rising and there's no signs of decreased function from the liver, we often don't have to treat the sarcoidosis in the liver in particular. I will say many patients with liver involvement will have involvement elsewhere in their body, and that'll be our focus of treatment. The spleen is actually even rarer for us to have to treat treat for. In general, if someone has nodules in the spleen and sarcoidosis, there's really not much that we do other than watching the patient's blood counts and making sure that there's no drop in their blood counts because their blood's being caught up in the spleen. So so next, I want to talk about two organ systems that we worry about a lot in sarcoidosis, but actually aren't usually impacted. And those are the nervous system and the heart. The nervous system, we generally find this based on physical exam, because if there's inflammation in your brain or spinal cord, the symptoms are very dramatic. We monitor nervous system involvement with MRIs, where we're able to see the inflammation, and our goal is to either get rid of the inflammation or make it so it doesn't worsen. The most important part of treating the nervous system is making sure that we have a really good nervous system exam. Because if we see a little spot of sarcoid and it isn't changing, and the nervous system exam is normal or isn't changing, that tells us that it's probably a a a location of scar, and doing high doses of immunosuppression may actually hurt rather than help. And then finally, I'm going to talk about the heart. So the heart is probably more commonly impacted in sarcoidosis than we think, but as Dr. MacMurdo said, if you don't look for it, you don't find it. There are some people, and these are probably the people who we miss, who have very small areas of granuloma in the heart and no symptoms, and they probably don't need any treatment. In this picture, the area of involvement's right here, just this little area of granuloma. Some patients can have larger areas of granulomas, or just granulomas in bad places that can cause dangerous heart rhythms. And these are patients who we would definitely want to treat, and we would also want to put in a device to prevent them from having issues with the heart rhythms. And here we do that in concert with our cardiologists. Some patients can have a very thick area of granuloma that makes it so their heart rate's very slow, and they can need a pacemaker to speed up their heart, as well as medications. And then finally, some patients just have granuloma and scar all over the heart that causes arrhythmias and heart failures, and they often need aggressive treatment. We monitor sarcoidosis in the heart with advanced imaging tests like cardiac MRI, which shows us areas of inflammation and scar. The MRI has a hard time telling scar from inflammation, and also PET, which is a type of test where areas of active inflammation light up. So the PET can be a more sensitive test that shows us exactly where the cardiac sarcoid is active. As I said, arrhythmias can be really dangerous. So we often monitor patients' heart rhythms at home with sarcoidosis to make sure that they're not having any dangerous heart rhythms if they tell us that they're having things like palpitations or we're concerned for cardiac sarcoidosis. And that can either be done with a Holter monitor, which is usually a 48-hour test, or now we've started using this Zeo patch in some patients that can actually stay on for 2 weeks. And then finally, I wanted to talk a little bit about non-granulomatous symptoms. And these are symptoms like fatigue and depression. You can see here in this study, up to 27% of people were depressed, up to 20% of people had chronic fatigue. And these are symptoms that generally aren't tightly linked to sarcoidosis activity, and they generally don't respond to immunosuppression, but they can be really debilitating for our patients. Here, we've started asking patients routinely through the fatigue assessment scale and the patient health questionnaire about their mood and their fatigue, so that we can have an early flag if someone is struggling. So with all that, my presentation's done. I think I saw a couple questions that I hadn't answered, so we can move on to questions if that works.
Yes, thank you, Dr. Harper. That was really wonderful. And there are a lot of questions coming into the chat. So I do want to apologize to everyone now. If I don't get to your question, I'm sorry. And I'm just taking a grouping here of some of the common themes that I see. So first, I'd like to jump back to you, Dr. MacMurdo. You talked a lot about triggers and mold and environmental triggers. We had a couple questions about testing. Are there any tests that can be done to identify someone's triggers?
It's a really good question. It kind of depends a little bit on what the trigger is. Unfortunately, we don't really have good testing for mold in the home. And a lot of testing that people advertise often is maybe not necessarily validated or regulated as well as it should be. In terms of actual mold exposure, really the most important thing we think is visible mold. So whether you can see or smell mold in the home. And if you are going to get your mold or get mold testing or get mold remediated, there's actually a sort of voluntary group, professional organization of people who do it well. I can put that link in the chat if that would be helpful, because I think it's really important to get a test that your doctors can use and get one that you can use and that's reliable. And unfortunately, not all of them are.
I was muted, but thank you for that. And I think that link would be very helpful for folks in the chat as well. And then we had a couple questions also about traumatic injuries, maybe triggering dormant sarcoidosis. Could you talk a little bit about that as well?
Absolutely, and Dr. Harper, feel free to jump in here too. But what I tell my patients is that we do know that stress and sarcoid really play a role. And I think sometimes when the immune system sort of sees a gap, sarcoid can become active. So I think about trauma as a stress on the body and potentially as a trigger to have sarcoid be active. Now, did the trauma cause your sarcoid? It's hard to know, but could it have made sarcoid more obvious? Potentially. The other thing is sometimes sarcoid's found when you have a traumatic incident because people start looking for things and start getting x-rays and getting testing. And so sometimes we can find it by accident, whereas it may have been there for a long time. But definitely anecdotally, people tell me a lot of the time their sarcoid came on after an event, after a trauma. That's not uncommon.
Thank you. Next, I will direct this question to you, Dr. Harper. A lot of questions around treatments. Are there any new treatments or medications for sarcoidosis in the last few years?
Yeah, so this is actually an area where we are really excited. So there's been kind of a void in new sarcoidosis treatments for a while. But there's actually 2 ongoing clinical trials, both of which will be active at the Cleveland Clinic, looking at targeted infusion medications that help calm down the inflammation in sarcoidosis. The process from trial to actual drug approval is actually a pretty long process, which is good, I think. And these are still early trials, but I I am hopeful that we really are starting to have some new targeted drugs. The other important thing is we're all working as a community to better understand how to use the drugs that we do have. But that's going to be a long process.
Thank you. And then how would someone get involved or sign up for a clinical trial?
Yeah, so that is a question I love. So if you're being seen at the Cleveland Clinic, if you just sent your doctor a MyChart message and said, "Hey, I'm being followed for sarcoidosis. I heard there's clinical trials. Do I qualify?" We have research coordinators who would be able to reach out and help. If you're not being seen at the Cleveland Clinic, the Foundation for Sarcoidosis Research actually has a pretty good website, has a very good website, and they have a section on there, I believe, of centers that are currently recruiting for clinical trials. Or you could come here, and we would love to let you know if you qualify. The thing I will say, though, is all of these clinical trials have very strict inclusion criteria because it is actually very hard to show in sarcoidosis that a drug works because of how everybody's different. So I don't want anyone to feel put off if they ask to be put in a clinical trial and they're told that there's nothing that they qualify for right now.
Thank you. The next question, we had a lot of questions also around testing. So how often would you all recommend patients getting any sort of diagnostic testing, MRIs, to see or to assess the progress of their sarcoidosis?
Oof. So that is really the hard question. I'll take a quick stab and then I'm going to hand it over to Dr. MacMurdo because I think this is one where you want 2 points of view. Testing's really hard in sarcoid because of how different everyone is. So there really isn't a routine structure. In general, I test when I'm changing treatment or when there is a change of symptoms. So for someone who's doing really well and isn't on any medication, that could be one time a year or less. For someone who is really sick, I could be doing tests every 2 to 3 months.
I'm in the same boat. I think there's no good rule of thumb here. It's very much based on how people are feeling because sarcoid's so different in everybody, and sarcoid does not follow a textbook or a rule book. But my general rule of thumb is that really I test if things have changed. So if people tell me that they're feeling different, that's when I start digging. I do check pulmonary function testing probably every 6 months to a year just for monitoring because sometimes people don't want to complain. And a lot of my patients sometimes don't notice that they're feeling really short of breath until things have really changed because people just think, I haven't worked out, I'm not moving as much. So I want to know about it early, so I do screen sometimes, but there's no hard or fast answer.
Okay, thank you. The next big topic we received questions on was drum roll, COVID-19. I know this word, this has been lingering over all of us for the past few years. So I think this is a really great topic to discuss. Have there been any links found between sarcoidosis and COVID-19? Are there any complications that COVID-19 presents for sarcoidosis patients?
Dr. Harper, do you want first stab or should I?
You can have first stab. I've talked a lot.
So have I, but I think, there's not great data about sarcoid and COVID yet. What I tell my patients and what I'm seeing is that a lot of the time after people have had COVID-19, sarcoid seems to become more active and sometimes flare up and misbehave, and that can kind of hang around for a couple of months to a year or so afterwards. I see a lot of people have actually been diagnosed with sarcoid after they had COVID. and have had a hard time with that because of sarcoid. But as far as I know, there hasn't been a lot of research kind of linking the two yet. I think sarcoid's still a little underloved here.
Yeah, I agree. It's hard to say. We don't have great data. What we do know is that people who are on a lot of immunosuppression may be at higher risk of COVID. So I definitely encourage all of my sarcoidosis patients, as they're able to keep up with their COVID vaccines and boosters, although thankfully that seems to becoming less and less of an issue.
You just jinxed us.
I know, it's my fault.
No, thank you for that. Also, a lot of topics on genetics, folks seeing, links in their families. Can you guys talk a little bit about the genetic links with sarcoidosis?
Sarcoid can definitely run in families. And we know that there's probably not one gene that creates the risk, but Dr. Harper's done a lot of this too, and we do see that families can have classes of sarcoid. I will pitch to my end that also environment classes and families. And so I think one thing that's really important is, again, teasing out that environment gene interplay and how those two things play together.
I think the most informative studies I've seen have been they did twin studies in Denmark and the Netherlands, where they showed that identical twins do have a higher rate of both of them having sarcoidosis, but they don't all both have sarcoidosis. So this tells us that even if you have exactly the same genes as someone else, you're not guaranteed to both get sarcoidosis, making it seem that while genes do play an important role, they aren't the whole story. And I saw someone asked how frequently is there generational sarcoid, and then and the numbers I've seen are somewhere between 5 and 15% of sarcoidosis cases are multiple people in a family in a row.
Most sarcoid does not have a strong genetic link, but
Mhm.
definitely if you have
Yeah.
a strong family history, I tell my patients that you should tell your kids to tell their providers that you have sarcoid because it may be relevant to them.
Yeah.
Thank you. I think that's really great advice. And then Dr. MacMurdo, can you talk a little bit about any household cleaners or cleaning chemicals that we might find in our homes that folks should stray away from if they have sarcoidosis?
Household cleaners are mostly okay, but one thing I'll say is people who have sarcoid can often have a lot of airway inflammation and almost can act like asthma. You can have a lot of wheezing, a lot of chest tightness. There are some cleaners, particularly strong scents and things we call quaternary ammonium compounds, which are the really strong cleaners we use a lot in COVID, that can sometimes irritate the airway. And so the less scented, the better. The less chemically, the better. Vinegar and water goes a long way. And just thinking outside the home, things like pesticides and insecticides, I really want people with sarcoid to avoid as well.
Thank you. And then my final question, I'll start with you, Dr. Harper. Talked a little bit about fatigue. So many patients are asking, how can they manage their fatigue? What should they be, telling their physicians? What do we do at Cleveland Clinic when we have patients that come to you with fatigue?
Yeah. And fatigue really is, I think, the biggest challenge of sarcoidosis right now. Anytime I go to a sarcoidosis conference, eventually all of the doctors are asking each other, "What do you do for fatigue?" Um, so in general, I think there are a couple things that are important. The first is knowing that it's very common, and to know that that it is real and biologic. The second thing is a lot of people have this. I call it exertional fatigue, where if you do too much in in one day, you're going to pay for it the next day. And a lot of patients tell me if they kind of keep an eye on it and they make sure they don't push it too much one day, they're able to find this kind of equilibrium where they're able to do everything that they need to do, and they're able to cut out the things that are really arduous and lead them to feeling really bad. The third thing that we always do here is we make sure that there's not some other reason for the fatigue. I generally look for sleep apnea, make sure there's nothing going on with the thyroid. Sometimes we'll think about cortisol or testosterone. While we do that, I will say I maybe 1 or 2 times have I actually found something, and it wasn't just the sarcoidosis. And I'll hand it over to Dr. MacMurdo now.
To echo Dr. Harper's point, one thing that I tell my patients is that often when people have sarcoid, they try and really push on the good days to make up for the bad days. And they feel really guilty about not doing everything they should be able to do and trying to squeeze it all in when they can. And that seems to make the fatigue a lot worse. And so I kind of echo your point. I basically tell people to keep a diary for a couple of weeks and figure out what you can do on a bad day and what you can do on a good day. And when you're having a bad day, don't try and make it a good day. You're allowed to feel unhappy and you're allowed to feel sick and tired. You've got sarcoid and it's causing problems for you. I say it's, again, sometimes medication can help, but there's not a slam dunk medicine for every person. So it's a lot of bit of figuring out what flavor of fatigue and what flavor of sarcoid you have and kind of finding the right balance.
Thank you for that. We are at time for the evening. I did want to give you, Dr. MacMurdo, and you, Dr. Harper, any last comments you wanted to say to the group before we sign off?
I think sarcoid awareness is really important. For all the work I do, the more we can diagnose sarcoid early, the better everything is. And so I think more events like this really, really help to make sure people get their sarcoid diagnosed and don't just spend the next 5-10 years being miserable and not knowing why. So thank you guys for coming. I appreciate it.
Yeah, and I just want to echo that, and also thank all of you for taking such a interest in really taking control of your disease. Having a chronic disease can be really disempowering, and I think it's really important that we do things like this where we're able to educate people so that they're able to manage their disease well on their own and with the medical team.
Well said. Thank you both so much for presenting, and thank you all to everyone for joining us. As a reminder, you will be receiving an additional email from us with our contact information. So if you have more questions, please reach out. And thank you so much. Have a great evening.